Good afternoon. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you all to our webinar series entitled The Medical and Public Health Considerations of COVID-19. Today, we are going to have a very interesting presentation entitled Integrating Ethics into the COVID-19 Response, Lessons Learned. Next slide. This month marks the one-year anniversary of the WHO's official designation of the outbreak of the COVID-19 pandemic. Over the last year, ACMT's had the opportunity and privilege to provide this webinar series most weeks throughout the last year on a variety of topics, and we really appreciate everyone who's attended. It's really encouraged us to get the best speakers and get the information on the most timely topics out to our listeners. And again, I'd just like to thank everyone for joining us today and throughout the last year as we've all learned together the lessons from the COVID-19 pandemic. Next slide. I'd like to thank our webinar series partners who've been instrumental in getting the word out to their societies about the webinar series, and they've often joined us as co-moderators, and we very much appreciate them. Next slide. This webinar and all our prior webinars are recorded, and they're up on our ACMT website at acmt.net/COVID-19 web. And this webinar today will be recorded as well, and will be up on the website within about 48 hours or so. Next slide. We also have developed FAQs on many of the webinar topics, and we encourage those if they want to explore some of these topics in more detail to sort through the FAQs. Next slide. There will be a Q&A at the end of the webinar. It's an important component of our presentations is to hear from the audience and to try to get to their questions and to their comments. We typically reserve 20 minutes, if not longer, for the Q&A. So as the presentation proceeds, please type your Q&A questions into the Q&A box or into the chat, and we'll try to get to as many of the questions as we can over the last 20 minutes or so. Occasionally, we'll go a little bit beyond the top of the hour if there's a large number of questions in the queue. Next slide. The speakers do not have any conflicts of interest to disclose. Next slide. I'd like to thank my co-moderator, Dr. Ziad Kazi, who's a board member of the American College of Medical Toxicology, and he's a president of the Middle East and North African Clinical Toxicology Association, which just concluded their annual scientific meeting this afternoon, or shortly before the webinar. And they did it virtually, and it was quite successful. And I appreciate that Dr. Kazi still has some bandwidth to join us this afternoon for our webinar. And Ziad, I think, is going to introduce our guest moderator.
Thank you, Dr. Wax. It's been a pleasure working with you and the team for the past year. It's also my pleasure to introduce Dr. Lisa Moreno, the president of the American Academy of Emergency Medicine. Dr. Moreno is a staunch supporter of our webinar series and has been our guest moderator previously. She's a professor of emergency medicine, director, Division of Research, Division of Diversity, Section of Emergency Medicine, director of the Latino Health Scholars Program at Louisiana State University Health Science Center in New Orleans, Louisiana. Dr. Moreno, would you like to introduce our speakers?
Yes, it's my pleasure to join you today, and I am honored to introduce our speakers for the day. That is Rachel Lakadu, who is the Director of Legal and Public Health Preparedness in the Center for Preparedness Education and faculty at the College of Public Health, University of Nebraska Medical Center by training. Rachel Lakadu is a Juris Doctorate or an attorney. Our second speaker is Abigail Lowe, and she is the Director of Ethics and Public Health Preparedness at the Center for Preparedness Education. She's the co-director of National Disaster Medical System Infectious Disease Training at the Global Center for Health Security at the University of Nebraska Medical Center. It's my honor to introduce our speakers today, and I'm anticipating that we're going to have a very, very exciting and active discussion. Thank you.
Thank you, Lisa. I appreciate that introduction. So I'm Rachel Luckadoo, and apologies, waiting for the mute to work here. I'm Rachel Luckadoo, and as Lisa mentioned, I am the Director of Legal and Public Health Preparedness at the Center for Preparedness Education at the University of Nebraska Medical Center, UNMC. And I'm so fortunate to get to work with my colleague, Abby Lowe, at the Center for Preparedness Education. As Lisa mentioned, Abby's background is in ethics. She's an ethicist, and for me, I'm an attorney, so we come at these questions from a different perspective. Abby gets to address the ethical side of things, and I tend to address the legal side of things. So we're going to be talking today about how we've integrated ethics into our COVID-19 response. I want to start by giving some background on our institution, UNMC, their involvement with COVID-19, just to give some context for the work that we've been doing. And then I will speak on the critical questions and ethics committee that we formed as a result. And then Abby is going to get into some of the specific ethical issues that we've discussed. So Dia, do you mind next slide, please? All right, so this is our campus. This is Abby and I's work home. We work at UNMC, which is an academic medical center in Omaha, Nebraska. It is also home to the largest hospital in the state, Nebraska Medicine. For the sake of this presentation, I will be referring to both as UNMC. So when I say that, I mean both of those entities. But like I said, we're the largest hospital in the state, so it's a very busy campus. There's a lot of transfers from other hospitals in the state. There's always a lot going on here. We are also home to the nation's only federal quarantine unit. So UNMC was very heavily involved in the 2014 Ebola outbreak. We were one of a few hospitals here in the US to successfully care for an Ebola patient. And as a result, we have become somewhat of a hub for issues of quarantine and biocontainment. So in 2016, we received funding from the ASPR, which is the Assistant Secretary for Preparedness and Response, to build a quarantine unit. And this unit had its grand opening in October 2019. And obviously we had no idea what was to come and had a little bit of a baptism by fire with the COVID outbreak just less than 6 months later. Next slide, please, Tia. So UNMC was pretty heavily involved with COVID from early on, very early on in the outbreak. So in early February of 2020, we were involved in quarantine operations for 57 individuals who were American citizens and their families who were being repatriated from Wuhan, China to the US. And they had to go through a 14-day federal quarantine, which was conducted at Camp Ashland, Nebraska, which is a National Guard facility just outside of Omaha. And this quarantine was run by CDC and by ASPR, but UNMC helped a lot with the operations and logistics of the day-to-day of the quarantine. Those folks were with us for, like I said, 14 days. We were very fortunate that none of them ended up testing positive, so they were all able to go home to their homes after that quarantine ended. This was a really interesting experience for us, though, because it was so early on during the COVID outbreak. There was still so much that was unknown about the virus and how it spread that a lot of the community members around Omaha were quite concerned about this quarantine going on in their backyard, if you will. So there was a lot of concern going on around us while we were dealing with this quarantine. Next slide, please. So right before that quarantine ended, we got involved with another quarantine exercise. So on February 17th, we received 15 passengers from the Diamond Princess cruise ship. And you may remember that was one of the cruise ships that was held off the coast of Japan due to a COVID outbreak. And so we had, I believe this is correct, but I think we had all of the COVID positive US passengers from that ship sent to our quarantine unit here at UNMC. So out of those 15 passengers, 13 of them had tested positive for COVID, and the other 2 were, I believe, spouses of some of the 13. So this made things a little bit interesting. Since these folks were positive, it wasn't just a straight 14-day quarantine. And this was a longer period. We had to wait for people to successfully recover and receive multiple negative COVID tests before they could be released. So we had these individuals with us all the way through March 18th. Some stayed for shorter, but the final person left the quarantine unit on March 18th, 2020. Next slide, please. So then right around that same time, all of these things kind of overlapped. Nebraska started to see community spread of COVID-19. So we had our first positive case here in Nebraska on March 6th. And then very shortly thereafter on March 19th, the first directed health measures were implemented here in the state. And those involved, limiting indoor gatherings, closing non-essential businesses, all those things that we are all too familiar with now at this point. Next slide, please. So as a result of all of this was a lot of activity. This was a lot of new ground. So Abby, myself, and one of our colleagues here at the Med Center recognized that there was going to be a lot of questions and a lot of issues to discuss with this COVID response. This was a really fast-moving, ever-evolving situation, dealing with a lot of unknown territory. So we wanted to create a way of stopping and asking the questions and thinking about the issues that needed to be addressed, even in the midst of the rush of the initial response. So on February 2nd, we formed the Critical Questions and Ethics group here at UNMC. And the intent of this group was really to provide a safe space for the discussion of ethical concerns, legal concerns, any concerns or issues that may arise during the COVID-19 response. We knew that this was going to be a really confusing time for people, and we wanted there to be a space for discussion where individuals could ask questions without any fear of reprisal or of it getting out to the broader public, just a real safe space, like I said, for discussing hard issues. Next slide, please. So the first CQE Open Table Forum was held on February 6th, and this was the day before that first round of 57 quarantined individuals arrived in Nebraska. We initially invited everyone that was involved in those quarantine efforts. So we had roughly 72 individuals we invited. This included people from our institution, UNMC. It also included individuals from local public health departments, the state public health department, and also some of our federal partners with CDC and ASPR who were involved in the quarantine response. And that initial meeting was all about setting the groundwork and building some familiarity and beginning to build a rapport with people so that they felt comfortable bringing up some hard questions. Next slide, please. And we've had really great success with these meetings. So we are over a year in, and we continue to meet every week for 30 minutes every Thursday at 8 a.m. So at this point, the invite list is a little bit smaller. We've got it down to roughly 40 people, and we typically have about 15 to 20 people attend each week. We've been really pleasantly surprised to see that the meeting has been a high priority for people who are in senior leadership roles here at the university and within local public health, as well as people who are doing more of the on-the-ground operational work in the COVID response. So some weeks for our meetings, we have specific topics to talk about, but most weeks are open to participant suggestions. So the way this works is every week, either Abby or myself will begin with an introduction, and then we'll ask if anyone has anything they want to discuss. And keep in mind, this is an 8 a.m. meeting. Most people are still on their first cup of coffee. They're not fully caffeinated yet. And so everyone's still kind of waking up. And so there's normally about 30 seconds, sometimes even a full minute of silence while we wait for people to suggest topics. And it's always, a little antsy. Is anyone going to have anything to discuss? But inevitably, someone will say, oh, well, if no one else has anything, I've got something I'd like to discuss. It's been really interesting to see how that has played out every week. We have really robust conversations that always go right to the 30-minute mark, if not a little bit over. And we've had quite a few people tell us it's their favorite meeting of the week. So I think just for the people that we have attending, having a meeting where nothing is really being asked of them, there's no requirement for anything for them to do, it's just a space to talk about what's on their mind, has been really beneficial. Next slide, please. So Abby's going to talk about some of the discussion topics that we've covered in these meetings more in depth, but I wanted to give a quick review of the types of discussions that we've had. So as the COVID response has evolved, our discussion topics have evolved. So our early conversations, those first few months of meetings, focused on issues surrounding quarantine. So we had questions regarding research ethics. We had some of the first quarantined individuals. Were we able to do research with those populations? These were difficult questions. One of the questions that was really near and dear, I guess you could say, to me is some of the legalities of quarantine. Now, if you'll allow me a moment here, this is something that I get kind of excited about, so I'm going to expand on this one. But quarantine and isolation law is really interesting. With this COVID response, this was the first time that the federal government had invoked federal quarantine in over 50 years. The first time prior to this was back in the 60s, and it was for one individual who had come back from Sweden and couldn't prove her smallpox vaccination. So when you compare the two, the scope and the range of this quarantine that we saw with COVID-19 was much broader, and it was for a virus that we didn't really know well. So what that meant was that carrying out quarantine and isolation was largely new ground. The CDC regulations that govern that quarantine effort had most recently been updated in 2016. They'd never been tested. And I think this was really interesting for our group to discuss, because since this was such new territory and unknown ground, there weren't always clear answers. And this was the case with a lot of the topics we discussed. It was a lot of gray area, and everyone had to be really comfortable with the fact that they wouldn't necessarily walk away from the meeting with an answer to their question, because maybe the answer just didn't exist yet. So as the meetings moved on, we ended up getting into issues that were more about clinical care and community response efforts. One of the big topics of conversation was crisis standards of care, which Abby will be covering more in depth. But we also talked quite a bit about the reopening of schools. We're a university, so that was something really relevant to us. When could we reopen campus? For any students who may live on campus, when would that be practicable? But we also were dealing with schools in the community reopening. We had a lot of employees, obviously, who have children in school. How did school being closed or open affect their ability to work in the midst of everything? So that was a big question as well. And then, as we all know, 2020 was just a tumultuous year all around. There was very heavy politicization of public health. There was a presidential election and all that comes with that. And then there were some very serious issues around racial justice and equity. And we wanted to discuss those things in our CQE group because they all played upon how we addressed COVID-19 in our communities and how we address some of our most vulnerable populations. And on top of that, they also caused distress for our employees and some of our community members. So we wanted to discuss ways that we could address those issues as a part of our COVID response. So as you can see from this list, it was a really broad range of issues that we covered, and it's continued to be that way as the COVID response has continued on for over a year now. We've seen these issues continue to evolve. So with that, I'm going to turn it over to Abby to discuss those ethical issues more in depth.
Thanks so much, Rachel. And you can go to the next slide, Dia. Thank you. I also just want to say thank you quickly for inviting us today. We're so thrilled to be here and share a little bit of our work. And as Rachel said, the pandemic has been a great way for Rachel and I to kind of step into these space and kind of think about how we can support response efforts. So we're thrilled to be able to share the work with you today. So thank you to Paul, Ziad, and Dia for having us today, and to the community for being here. So as Rachel said, I'm going to talk a little bit more about the kind of ethical issues that we've seen over the course of the last year. I'll give you a few kind of overview of some of the themes that we've heard about, and then we'll kind of do a little bit more of a deeper dive into an example issue of crisis standards of care. And I think, as Rachel and I were talking about giving this presentation, part of it is the methodology of having a critical questions and ethics open table, a forum where these kind of issues can be taken to and kind of worked through with a group, but then also thinking about the ethics that we've seen, the patterns and themes that have emerged over the course of the last year. Next slide, please. So as Rachel commented on, some of our early conversations were on the issues of clinical ethics and research ethics, but contextualized around the federal quarantine. And so, I think in my mind, how this played out was really to look at the ways that we all initially were looking at the issue of federal quarantine and the ethical issues that arose and that CQE fielded in those spaces were around clinical ethics and research ethics. Again, really early in the pandemic. So the clinical ethics issues were obviously fascinating. Having the federal quarantine unit used in the early stages of the pandemic, thinking about issues of cohorting quarantined individuals, people who wanted to be in the same space while we were trying to keep people separated, the issue of testing that Rachel brought up too, thinking about what a negative test meant was longer duration in quarantine. So I think these were really complex issues that happened also in a landscape where there was partnership with federal entities, as well as the academic institution UNMC and clinical partner Nebraska Medicine. The issues of research ethics were also really emergent as well, trying to kind of consider how, what is the place of research in a pandemic with an emerging disease that we don't know a lot about. Where and when is it appropriate to start really thinking about research? And I think, the tension of there being some ethical imperatives to really learn as much as we can, as early as we can, in order to reduce suffering. The more we learn, the more we're able to kind of expedite treatment, as well as preventative measures, as we've seen, learning about masking, learning about the effectiveness of social distancing, and all the ins and outs that we come to understand through our understanding of the virus. So those were kind of some of the initial issues that we really talked about. And I think the important piece too, in terms of a methodology, was that at that CQE open forum at that moment in time, we were really looking at talking with people who were all working on the issue of federal quarantine, all part of that operational space. Next slide. Thank you. So about midway through 2020, our conversations start to shift as we're not talking anymore about federal quarantine. We're talking about actual pandemic response. We're talking about testing. We're talking about academic issues in terms of as an institution, how does an institution handle testing or returning to campus? How do our public health partners and local public health handle testing of the community? What stigmas are involved that we think about Crisis standards of care, which I'll talk a little bit about later, became something that was a recurrent emergent kind of operational conversation that we'd had, as well as vaccination efforts. So again, I think in terms of how CQE operated with this really interdisciplinary stakeholder group, was we continued to talk about those areas of connection, testing, vaccination, clinical care, but we're all kind of talking about it from our own spaces. And so the conversations become less detailed and more operationally oriented, more broad in their perspectives. So we can go to the next slide. So let's go ahead and delve into one of the issues that we talked about, just to give you kind of an example of the kind of discussions that we had and the things that we were thinking about within the open table forum for CQE. Crisis standards of care was definitely something that we talked about early on in the spring, and then it became something that we talked again about in the fall. And just to take a step back to make sure you're all familiar with crisis standards of care, I think broadly speaking, when you think about crisis standards of care, it is about thinking about resource allocation, low supplies, staff, space, and thinking about how do we provide clinical care with less than is optimal, right? And so crisis standards of care became something that, you know, how do we plan for that scenario? How do we plan as a state? How do we plan as a hospital? You know, those conversations were definitely front and center in a lot of our discussions. And I think the purpose of crisis standards of care is to provide unified, transparent framework that supports consistent provider decision-making about the use and allocation of scarce medical resources. So really to guide that decision-making and to ensure it's consistent. We don't have everything we need. How do we provide the best care to the most patients possible with what we have currently? So I think, you know, looking at the United States there, as is on my slide, there are 37 states that have official state-backed crisis standards of care plans. And, you know, this is something that Rachel became really involved into more broadly, as thinking about Nebraska and how when you don't have a state-backed plan, what does that mean from a legal perspective? How do we think about that in terms of having conversations about it? And for us, it took on kind of a community engaged way of moving crisis standards of care forward. So Nebraska is one of the states that doesn't have an official state-backed plan. But, you know, as we were working through how do we do this, we worked together as a state broadly with stakeholders, and this was an important intersection for CQE in terms of really communicating and coordinating about, okay, what are needs? How do we put people in touch? And our plan, our Nebraska plan, again, was broadly reviewed by clinicians across the state, as well as healthcare associations and hospital associations within our state. So I think it just took on a different approach to operationalizing the plan. Next slide. So what are some of the key ethics issues that come up with crisis standards of care planning? And I think, you know, this is pretty standard when you're talking about crisis standards of care, whether, no matter what state you're in, whether it's a state with a backed plan or not. But, you know, I think issues of resource allocation often land on themes of fairness, right? If you're saying there's not enough, how do we really ensure that we put planning guidance in place that that ensures that we do things as fair and consistent as we possibly can? I won't go through each one of these line by line, but I think another important key ethical value in crisis standards of care is the duty to steward resources. Part of what crisis standards of care planning seeks to do is extend the availability of key resources and really minimize the impact of shortages. So it really puts an onus on leadership, on people who are in healthcare facilities to really think about the stewardship of those resources, extending the allocation, making sure we're communicating and coordinating in a way where people can reach out and get what they need. The other one I wanted to mention is transparency and decision making. And I think transparency is something that we talk a lot about with public health emergencies, is being able to be honest and transparent about what we know and how we're going to approach things given what we know and what we have access to. And I'd say that, accountability also becomes an important key principle with crisis standards of care, ensuring that there are some checks and balances for how we operationalize, those spaces where we are essentially rationing what we have in order to give the best care possible as we can. So next slide. So I wanted to bring up a couple, as we kind of worked through some of the ethical values that are important, a couple of the key themes in crisis standards of care planning that we certainly discussed at length within CQE, but that aren't, necessarily specific to Nebraska or our discussions. So I think settings of scarcity are really important, and those became things that we were thinking about. If you think early in the pandemic, when you're thinking about crisis standards of care, we were certainly talking about ventilators, and we were thinking about PPE shortages. So if you're a healthcare facility and at the time you're trying to ensure that visitors could come, you're thinking about, well, what do we do when there's not enough PPE? Does that impact our visitation policies? How does that play out? Later on in the pandemic, I would say more towards the fall, we were having conversations more about staffing, not having enough staff to really, maybe having enough PPE and having enough ventilators at that point, but not having, or concern around staffing. The other issue that often is discussed around crisis standards of care is clinical criteria considerations. There's been a lot of discussion about SOFA scoring, which is a primary clinical scoring that is used in a lot of crisis standards of care plans. And it's received a lot of critique. And so we did spend time discussing its limitations, as well as discussing how it does support consistent decision making. And it is one of those features that it's what we have. So how do we use what we have to really kind of bolster what we're able to do within the clinical community that is providing care, all the way from EMS to a critical care room. So the other conversation we definitely spent some time on is, how do we think about advanced care planning in the schema of crisis standards of care? How do we ensure that there are ways that we're asking people about what they want and having those conversations and thinking about where those fit when you think about critical questions and ethics, again, kind of broad groups discussing that. So different based on a facility provider to someone from public health who's considering it to someone from EMS, but having those conversations around what are the conversations we need to be having around advanced care planning. The idea of transparency flowing all the way through, how do we communicate this effectively, compassionately, consistently? What does that mean for a healthcare facility? What does that mean for EMS? What does that mean for public health? How do we coordinate and ensure that those are consistent? And then, as Rachel had kind of mentioned, we've had ongoing conversations about in the section of crisis standards of care planning, but also more broadly about those who have been disproportionately impacted by COVID-19, who have shouldered the disease burden, particularly early on in the pandemic, how it impacted those in our communities who worked in essential industries, and the way that we saw, that really needing efforts that mitigated the inequities that we saw in terms of disease burden. So those are some of the things that certainly I don't think are unique to Nebraska or unique to crisis standards. They're unique to crisis standards of care, but you would definitely, I would think there were similar rooms across the country discussing those same things. But I did want to move on to the next slide and talk about a few things that I do think might have been a little bit more unique to Nebraska when you're thinking about crisis standards of care. I think the issue of having a plan that's not backed from the state by the state, though there are definitely legislative efforts that are moving forward in our state right now to kind of move in that direction. But again, with crisis standards of care kind of planning, we weren't there yet. And so we did have to think about, what does it mean to have really a community engaged approach to planning, where we're coordinating with facilities and providers and health departments to some extent across the state. But there are limitations from, who gets to decide. And so that's an interesting dynamic that has pros and cons, right? I think some of the pros have been watching people really kind of lead and do this together and really move towards consensus on the approach we take, which I think for our state specifically has been a really great approach, because when you have stakeholders from across the state working to create planning that fits the needs of their facility and their community and their region, then you get a better plan. I think it's a little bit slower in terms of, if you have a state-backed plan, having the ability to kind of have the authority to move in a direction and kind of chart a course and tell people how you're going to move forward. So the other thing I think was specific to Nebraska that we spent a good deal of time talking about in CQE, and Rachel and I obviously spent quite a bit of time thinking about this as we became involved more and more in crisis standards of care planning, is how do we really ensure that crisis standards of care planning suits the needs of our rural areas and critical access hospitals, which was something that we really wanted to ensure that any planning on our end did that and was engaging with those communities, with those providers, with those regions, with those healthcare leaders that could speak to that and really revise and adapt the plans according to the needs of those communities. So I think that those are some of the really key issues that within CQE and our conversations led to other important developments, but they arose, again, like Rachel kind of spoke about, from someone just saying, hey, I'm really concerned about our critical access hospitals. Of course, we've all seen some of the stuff that the National Academies is doing on crisis standards of care, or the IOM work on crisis standards of care, but how does that meet the needs of Nebraska, of our critical access hospitals, of our communities across the state, which I think was a really kind of great, full circle timeline of how CQE could kind of usher in discussions that were generative and moved us forward, though there wasn't necessarily an answer provided at that Thursday meeting. So we can go to the next slide. So I think with the case of crisis standards of care, I wanted to kind of close out conversation on that specific case with what I thought were some of the key takeaways, which were about connections. So I think as we discussed those very issues that I just walked through, I think the important takeaway and the important spot that CQE really provided was providing connections between public health, academic leadership, hospital leadership, that moved the work forward in important and in timely ways. So the space that was established, it allowed for that original comment around, oh, I have a concern about this, what's being done about this. but then it allowed for connections between the right people that allowed for us to move planning forward. So it supported communication, collaboration, and coordination around crisis standards of care planning for our state specifically. So I thought it would be a good kind of case study example about how the method of using an open table can lead to not only generative conversations, but important connections for key issues in pandemic response. Next slide. So kind of to just close us out and to move into the next part of this conversation, we have a few, Rachel and I have a few top 3 lessons learned from having an open table space. And I think for us, the value of an open space for discussion really is about providing that space for thinking. Having people be able to bring up issues as they observe them and just offer that as, what do people think about this? It allows for there to be a place for thought without necessarily always needing, okay, but then it has to move to X, Y, Z, or I have to have these 3 solutions. This became really important in the middle of pandemic response, right? Because you never know what you're really going to be triaging from week to week. And so the ethical issues then are always really constantly evolving. And so I think having a space where you can say, you know, last Thursday we were talking about this, but this Thursday we're going to be talking about something completely different, and having people be able to kind of come and know that they have a space to talk about whatever's pressing on them at that moment. The other thing that I think both of us have come away from this year recognizing is that this type of open forum, this type of open discussion space could be used for groups outside of COVID-19 response. Again, with those intensive purposes of really providing a space for thinking to happen, for discussion to happen, without, you know, necessarily having to have a solution at the ready. Solutions, as I kind of brought us through that example, have happened as a result of CQE, but I think having a space where people can not be responsible for solutions in that moment, but just be able to focus on just thinking with others, making connections, hearing what others are doing or how they're handling it, became really a valuable thing in and of itself. So with that, I'm going to go ahead and close out our presentation and turn it over to Dr. Moreno for discussion.
Well, we have some really fascinating questions that have come in. One of the things that a few of us are curious about are some actual cases that you opined on. So if you could share with us some actual ethical cases that you were asked to give an opinion on, and perhaps some of the most difficult ones that you were asked to give an opinion on.
Sure. So I think, you know, I won't speak for both of us, but I think we'll probably do this a little bit in broad strokes, because I think, as we've made clear in this presentation, one of the benefits of this group was making sure everyone felt comfortable and safe to share their concerns without them being exposed more broadly. So I think I'll answer this in more broad general terms, but I know early on we dealt with some questions of, how do you deal with individuals who are being kept from visitors in the hospital, you know, who are COVID positive, who may be dealing with end of life issues? What do we do in those situations? How do we get them access to their families to say goodbye? You know, that was a really difficult issue. And I think that was one of the first questions we had. And so to deal with something that was that level of intensity from the beginning was interesting, I think, for Abby and I, because it wasn't like we got to just deal with some softball situations from the beginning. Things were very difficult right away. So that was one of the cases and concerns. That was one of the first things we dealt with. We also dealt with quite a lot of questions about, and Abby's done more with this, so she can speak to this better, but we dealt with a lot of issues of outbreaks among essential workers, particularly among workers in meatpacking plants. That's a big industry here in Nebraska. And so that question came up a lot. So I mentioned those two to show there was a really wide disparity in the types of questions that we received. Some were more granular and at the clinical level, and some were broader and community-based. Abby, what are your thoughts?
Yeah, those are a couple of great examples. The other one I would say that came up recurrently that was really tough, and I don't know, some of the challenge of questions like this is, and the way they come to CQE is people are just expressing concern and don't necessarily have a specific, here's my question, can you attend to it? They're just saying, this is really hard. And so I think one of the things that came up a few times was about long-term care. And so really thinking about how do, especially those communities in long-term care who are locked down for quite a while, but thinking about what that actually meant for those folks in long-term care facilities, as well as those folks taking care of people in long-term care facilities, in their ability to give the care that they would have liked to give, and the stress of social isolation, both on residents as well as their care providers who are having to, feel that sense of social isolation from those in long-term care facilities. So we had quite a few folks that were either helping with some of the infectious disease training in long-term care facilities, as well as I think a couple that are part of long-term care facility leadership at CQE that brought those issues to the group to discuss. And I think those became kind of central conversations that we had about social isolation in the pandemic. And, that definitely bled over into other, of course, they weren't alone, but it was definitely a focal point of that conversation for us.
So one of our attendees has asked the question, what do you say to people who are required to isolate? Individuals living in long-term care, people who are not permitted to visit a dying loved one. What do you say to them when they tell you that this is a violation of their civil rights?
Well, this was a tricky issue. And I think this was something that we've all seen across 2020. It's been that impossible balance of community good and individual rights. And that's one thing when you're telling someone to wear a mask to a grocery store, that feels like a very manageable way of maybe taking on an individual burden for community good. But that's very different when you're telling someone you can't go to a hospital room and say goodbye to a loved one in person. That's very difficult. So I think what we tried to do within our group when dealing with those questions is, I think, really go in with a little bit of grace and understand that this is difficult and this is unknown and new, and people aren't used to dealing with questions like this, and helping people see that, yeah, there's going to be some really horrible, honestly, hard individual sacrifices that have to be made in order to better, for the community good. Abby, I don't know if you have a different response for that.
No, I think you did a great job of that. But I do think, Dr. Moreno, what you're kind of pointing to, which I think is definitely a theme that has been recurrent, is this idea of individual rights versus really a sense of interdependence or solidarity, of being able to care for us as a community, as a connected to one another, deeply connected to one another, versus autonomous individual kind of preferences. And so it's definitely been a tension that we've discussed a lot, and it does seem to require a certain mind shift that is not easy all the time, to think about your health is this, that our health is deeply connected to one another. And so how do we act in the best interest of a community health is a conversation I think that has definitely been something that we've discussed and a theme that's been part of our conversations.
Can I follow up, Lisa, and ask Rachel to follow up on this? Have there been any legal cases during the past year where someone really wanted to, I mean, I know you tell them this is for the best of everyone, and they said, no, I don't agree. I'm going to proceed with this. Has there been any legal cases that you heard about in the U.S. or the world?
Well, I'm sure there have been in the world. You know, I'm not sure right now of any individual ones that are coming to mind. I have said many times that I think once this pandemic's over, if someone wants to make a lot of money, they could just go into COVID litigation, because I have a feeling we will be seeing lots of lawsuits regarding different issues that have come up during the pandemic. Some of those questions I don't think have been really addressed well yet, but I think they probably will be in the future. I'm sure we will be seeing lots of cases like that.
Thank you.
Mm-hmm.
So when you talk about the community and the benefits of the community, one of our attendees, Dr. Ball, is asking, could you speak in more detail about the important and challenging interface between bioethics and health equity in the midst of a pandemic where fair and equitable allocation and access is much easier said than done?
That's a great question and a hard question as well. But if I'm hearing it right, the tension between bioethics and health equity in the operations, is that?
Yes, that's what he's asking.
Mm-hmm. Yeah, and I think it has been interesting as an ethicist, as a bioethicist, getting involved in issues of essential interest industries. How do we prioritize and support infection prevention and control in meat processing plants? When the pandemic started, it was, who would have been thinking that we're needing to go into meat processing plants and set up, plexiglass and test the air and think about how those workers are protected. And a lot of the literature at that point, early spring, anytime you talked about frontline workers in an infectious disease, really spoke to healthcare, hospital employees. They would speak all the way to kind of from janitor to surgeon, but there wasn't a lot there in terms of ensuring that what is owed to those workers in a pandemic, when we're saying, there's a declaration that they must maintain operations. They're an essential industry and they're going to work and they're getting sick. And so what's owed to them from us as a community? And I think that it's an interesting emergence of something that I think was not previously really thought through in the literature prior to, and that has become part of the conversation. And I think the way, the regulations, and Rachel maybe can speak to more about this, but ensuring worker safety in a pandemic setting, that's what's owed to them. Regulations that ensure there's an equal playing field in terms of what is owed from an industry to a worker in the middle of a pandemic would probably be kind of my initial response to that question. Hopefully that's helpful.
Yeah, and I think, Abby, you mentioning that about the regulations being what would help those workers, I think that issue, kind of similarly to the crisis standards of care issue that we dealt with, some of those questions required and called for a regulatory answer. But as we all know, those kind of answers, regulations and new statutes, take quite some time to put into place and to be passed and to be agreed upon. So it was very hard with some of these questions to know that the answer that was needed for them would maybe not come until after the fact. As we've seen here in Nebraska, I saw this question was in the Q&A as well, about us having a crisis standards of care plan in Nebraska. because of some of the work that we've been doing, we're seeing that move forward in the state, a plan being adopted, but it probably won't be formally adopted by the state legislature until 2022, if it is. So it's been very interesting with some of these questions to see where there's a legal answer needed. It's going to take some time before that actually can be put into place.
So while there aren't those legal standards, some of our attendees are also asking questions about whether you work directly with hospital ethics committees when very specific cases arise where there's an ethical issue, and have you worked with them to develop a framework or a group of a stepwise procedure for working through an ethical question that is brought to a hospital ethics committee about a specific patient situation?
Well, I can let Abby answer this one as she's our ethics guru, but we were very fortunate in CQE to have the lead ethicist for our partner hospital, Nebraska Medicine, be a part of that group. So we had a very natural connection with the ethics committee for those hospital operations, which was a really nice thing for us to be able to have, and to have another opinion of another ethicist. But Abby, I'll let you answer the ethical framework question.
Yeah, that's a great question. I would say, you know, the questions that CQE fields are probably a little bit different than a hospital ethics committee would field, just because they're more centered on the COVID-19 response. So I think generally speaking, they are pretty public health focused, unless we have an individual issue and we want ethics consult on it. The other thing that I think, you know, what I think CQE has done is that Rachel and I open this table, but we don't necessarily provide direct guidance based on the questions asked. It is really for people to come to an open space and express concern. We do offer that each week, but we don't provide anything necessarily in return in terms of like, you know, here's a report or anything like that. So I think that that's how we have operationalized this meeting, if that helps. So in terms of a framework, it's more of an open table where people can come and kind of express these challenges. But there's never anything kind of directly given back at the open table either. Is that fair, Rachel? Yeah.
I would like to ask several questions about vaccinations. You know, we look back on the year with the initial questions about quarantine and masks, and you know, now we're entering into a new phase with vaccinations. And of interest, you mentioned that the quarantine regs had not really been used, you know, since that Swedish traveler had refused to show smallpox, you know, vaccination. And you know, currently, you know, many schools require vaccinations to attend schools, et cetera, et cetera. So as we go from no vaccine to limited vaccine to in the near future, likely an abundance of the vaccine, you know, how are we going to deal with folks that refuse the vaccine, with implications that have a major public health consequence and also resource consequence. And even though we're not quite there yet, as we plan to get there, you know, what are some of your thoughts about how we're going to approach that from an ethical consideration?
Yeah, I think that's a good question, Paul. And I think it's very interesting, you know, all the vaccines that we currently have approved for use here in the US are all under an EUA. You know, they don't have full FDA approval yet. And as such, they can't be required. Some folks are saying they can. It's been very interesting to see. You can ask 10 different lawyers that question, and I think you'll get 10 different responses on whether vaccinations can be required. So I think this is an area that's going to continue to be rampant for discussion. And I think that idea of forcing people to get vaccines, that doesn't necessarily gel with how we've done things as a country. You know, for schools, yes, we require vaccines. It's been interesting to see, I don't know if y'all have seen this, but Rutgers, I believe it was just last week, required that all their students receive the vaccination, but they did not require the same thing of their faculty and employees. And so I think it's interesting that in applying these vaccine policies, there's not yet a real consistency. And I think it's because everyone's still sorting that out. Abby, what are your thoughts on this one?
I would agree with you. I think it is. I think as it with so many things and that we've talked about, it will be how it's done that I think, and contextual. So your example about the university is, I think, appropriate and excellent in that, you know, I think it will have to be contextualized, and there will be a bit of the devil's in the details in terms of how it can be done in a way that is right. So.
And I think also there will need to be some very clear national level guidance on that question. You know, with so much of the pandemic, we've seen decisions being made piecemeal across states, and that inconsistency has led to a lot of confusion for both healthcare and public health workers. I hope that we begin to see more national level guidance just for the sake of consistency of how these policies and procedures are applied.
And I might jump in too, just because that kind of struck a chord with me. I think one of the things that with the vaccination strategies, with crisis standards of care even, is really allowing for channels of engagement and participation with communities, with trusted voices within communities, really attempting to engage that bi-directional communication allows for trust. I think it breaks down some of the politicization that's happened over the course of the year, and allows for people to work together on issues. But that's a lot. That's hard work to really do that, and it really requires having broad networks where you can engage with key communities, engage with community organizers in areas as well if you have vaccine hesitancy, to really ensure that the planning that you're doing and the way you're operationalizing the work meets the needs of those communities.
So one of the questions, and I think this is more because it refers to standards of care. And the question is, aren't standards of care actually established by the way treatment is rendered by healthcare professionals? And so how does that impact crisis standards of care?
That's a good question. And I will say, you know, apart from the CQE group, one of Abby and I's other main areas of focus over the last year has been crisis standards of care, specifically in Nebraska. So this is something we've dealt with quite a bit. And I think that's a very good point. Standards of care are established by the treating community. What the legal side of that is if the state, for example, here in Nebraska, if the state ends up formalizing a crisis standards of care plan that provides immunity and liability protection to providers, then those providers can act under a reasonable standard of care and know that they are not going to be subject to liability later down the road. So it's kind of a cross section of provider-led standards and guaranteed immunity as well. Guaranteed immunity with good faith action, obviously all the necessary caveats there.
And then Abigail, I'll throw in a question here to Abigail about the composition of your group or the experts that participate in your group. Did you include, for example, safety officers or safety professionals or clinicians? Of course, I'm sure you had clinicians, but what about people in the occupational health and safety department or section?
For CQE?
Yes.
Yeah, there's a handful that have kind of that occupational health focus that attend. We have someone who is in agricultural health and safety that could kind of speak to some of those issues. And then a lot of our colleagues have that come from the Department of Occupational Health within the institution we're at, UNMC, as well. So yeah, we did have some intersection there.
And did you have to deal with any employees that, for example, were not comfortable with the current PPE practices or with the care of patients infected with a novel virus? And were there any issues like that? We've heard some things in the news about employees having to be let go. You know, that was initially at the beginning. I don't know if you can share some insight into these kind of situations.
I don't think I heard anything about employees being unhappy with the PPE. I think we heard more about the shortages of PPE and trying to figure out, you know, how to ensure everyone had safe PPE to wear. Rachel, I'm not sure. Did you hear anything on that end? No.
No, I would agree. I think we heard more about the shortages. I think also we had the benefit, as I kind of mentioned in the early part of our presentation, is our campus was heavily involved in the Ebola outbreak. And I think to some extent that benefited our employees in that they were a little more used to dealing with, not that we deal with that regularly, but they've been used to hearing about issues of infectious diseases and biocontainment and quarantine here on campus. And so we didn't hear a lot of issues of employees not cooperating with PPE. We were very fortunate to not have any of those issues.
No, I think, yeah, there was some news in the media, not in Nebraska, but elsewhere. I think there were some reports of people being let go.
Yeah.
I was just wondering what the legal side of this was, and you know, ethics versus law.
Right. And Abby and I are very familiar with that. You know, there's the wanting to do the right thing and what the law says is the right thing are not necessarily always the same thing.
I think that's one thing that I've really take away from this webinar today is that there's no really black or white answer here, or, you know, right or wrong answer. It's really more a process of thinking and discussing, and it's more of a continuous engagement. I don't know if Dr. Wax or Dr. Moreno, I know we're already 4:07. I don't know if you have a couple more questions before we conclude.
The only topic that is in the Q&A box that wasn't touched on is the ethical issue about shutting down someone on public media if they're speaking out with an unpopular opinion. And I think this, you know, also speaks to something Dr. Kazi alluded to, and that is like doctors being fired because they spoke out on social media about the fact that their emergency department or their intensive care unit did not have adequate PPE, and they were, for example, wearing the same, you know, N99 for 4 days that they were working. So what are the ethical issues of shutting someone down on social media if they are speaking out about something that is unpopular?
Yes, there's a lot involved there. And I will say I received this question not from a healthcare perspective, but from public health. We had a number of public health departments around the state who would post things about mask mandates or whatever rules they had put in place in their jurisdiction. And they had people in their communities who would comment on Facebook or Twitter, wherever the case may be, with pretty vitriolic responses and really attack this public health workforce. And, you know, sometimes those health departments would want to delete those comments because maybe they would have misinformation in them about how masks work and, you know, all the things that we've seen on social media that's been so pervasive and confusing during this pandemic. And it was difficult for public health departments because they are a state entity. So under First Amendment rules, they can't delete comments. They can't, you know, block that access to speaking in that public forum. So I think that was really hard for those public health departments to kind of have to let those comments that some were downright abusive, to be honest, stand on their social platform. In terms of healthcare, you know, that wasn't an issue that we ran into as much. We did have a lot of really outspoken doctors and nurses here at the Med Center who were saying things in a beneficial way to the community about needing to wear masks and doing the right thing and getting vaccinated. And so we had a good social media presence in that way from employees. But I know that hasn't been the case for a lot of facilities, and that's really difficult. And that's the age that I think we are living in. And as we have all seen, there has been so much misinformation spread during this pandemic through social media that I wish sometimes that there were easier ways to shut that down. Abby, do you have any thoughts on that one?
I think, no, that was great. And I think I will say I did notice throughout Nebraska the really reliance on our medical health professionals, our healthcare workers, to get the message out, especially early on, about what, you know, what they needed from the community. And that happened, you know, at the Med Center where Rachel and I are, but it also happened in Scotts Bluff and in places across Nebraska where they relied on their healthcare community to have kind of almost a white coat press conference on the steps of hospitals to kind of get that message out. So again, that idea of really utilizing trusted voices within a community to disrupt some of the noise and politics going on with kind of having people hear a consistent message that they can kind of follow through on.
Great. Well, I'd like to wrap it up at this point. You know, thanks again for an excellent presentation from Abigail and Rachel. Really tremendous. And thanks to Lisa Morano for providing the moderation and the intros, and to Dr. Kazi for his contributions as well. If we could just go to the next slide, please. We're going to continue our webinar series after taking off a couple weeks with this upcoming webinar on the SARS-CoV-2 variants on Wednesday, April 21st, again on a Wednesday at 3 p.m. This should be very exciting and timely presentation. One of the New York City scientists who discovered one of the variants herself is going to be giving the presentation, so it should be really excellent. Next slide. The entire collection of webinars can be found in our prospectus, which is available on our website. And again, this presentation today has been recorded and will be placed on our website within 48 hours. If anyone has any specific questions about this webinar series, you know, feel free to communicate with us at info@acmt.net. And again, thank you very much.